Alrighty, so recording, sharing. Yes, okay. So we're going to talk about depressive disorders and antidepressant drugs. Our textbook, gosh, I don't need to look at myself. There we go. Our textbook goes into a lot of detail on these topics. My job is not to make you a psychiatrist. My job is to have you have a general understanding as a general nurse who might be working with patients with depressive disorders. Is my clicker going to work? That's going to be annoying. Okay, there we go. So I have the objectives here, as always. It looks like a lot of objectives because I cover the disorders and the drugs kind of together in one lecture instead of two separate lectures. I think they go together much better. And now my computer's telling me my volume is off. Where's my volume? Sorry, if I'm recording this, I want to make sure I have my volume on. Why is... Okay. And it's not giving me that little bar that I show my volume either. Okay. Can you record backup for Brie? Just in case my volume is... In case she has it with no volume. Thank you. So... a diagnosis of depression. I don't know how to get rid of that because it's not showing up on my end, that bar. So a diagnosis of depression. When somebody is being diagnosed with depression, yes, we're going to see sadness, emptiness. We might see irritability. What is really important here is that the mood causes distress. All of the psychiatric disorders that we're going to talk about, to be a disorder, it needs to be causing distress to the patient and or impairment in social and or occupational functioning. For somebody who is in school, school is the equivalent of occupational functioning. So it needs to be causing impairments. We all have days where we feel sad, where we feel empty, where we feel irritable. But is it causing us distress or impairment in functioning? Depression is one of the most common psychiatric diagnoses you will see. I don't ask you statistics on exams, but just to put this into perspective, most people with depression, even though they're not hospitalized, 70% of your psychiatric hospitalizations are going to be related to depression. And 50% of suicides are related to depression. So it's a very important topic. Signs and symptoms of depression. Again, we are not diagnosing, but you need to be aware. Depression is going to have a depressed mood. That makes sense. Sleep. Either the person sleeps all the time or they can't sleep. One extreme or the other. Anhedonia, decreased interest in activities. I would know that word. There may be feelings of guilt, decreased energy levels, decreased concentration. Appetite is one that goes either way. Some people self-soothe with food. Some people have no appetite. Psychomotor is described either as agitation. They just need to move around. They cannot sit still. They're fidgety all the time. Or psychomotor retardation, which I usually don't like that word. But in this sense, it means all of your motor skills are very slow. A couple years ago when I was at York, we had a patient who it took her about half an hour just to get out of her chair. And it wasn't because of a physical impairment. It was because of her depression. And then we always want to monitor for suicidal ideations. Major depressive disorder, when we are diagnosing this, we again are not the ones diagnosing, but a diagnosis is going to require at least 2 weeks of a depressed mood, loss of interest, loss of pleasure. So this is not just an isolated event. This is ongoing. and then multiple symptoms nearly every day. Very important, the patient has never had a manic or hypomanic episode. Everybody watch the info on bipolar. What is manic? What's a manic episode? What's a manic episode? Abigail?
They have very increased like energy, they probably not sleeping, they want to do a whole bunch of things, they're irritable.
Exactly, that's perfect. So manic, super, super high energy, interfering with your ability to function. You are everywhere and nowhere. Don't want to sleep, don't want to eat, talking rapidly. Hypomanic, what's hypomanic? Ada.
Energy is equal, it gets higher than your baseline, but not to the level of.
Yeah, this is in the slides. I have a picture of a person like walking 10 dogs. This is, you are super productive all the time. You are go, 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 go. You're focusing, you're getting stuff done, but you are way above baseline. Persistent depressive disorder. This is also called dysthymia. This is Eeyore. This is the person that's just down. It's just my day-to-day experience. Every day is a little bit blue, not much going on. So you're not as depressed as major depressive disorder. You're kind of below that line. Everything's a little bit, the cup is half empty all the time. And this has been going on for at least 2 years. So this is long-term to get this diagnosed. It's chronic, mild, but chronic. Premenstrual dysphoric disorder. This is an actual diagnosis. This is the mood swings related to menstruation. Symptoms can start as early as 1 week before menstruation and last as long as 1 week afterwards, which if you do the math with that, you're like, oh, great, you have 1 week a month where you don't feel depressed. So this is more presenting not just as depression, but as mood swings, maybe tearfulness, irritability, anger, anxiety, and it's around menstruation. So that can be a reason that somebody might be on birth control to kind of help regulate those hormones for that. Depression in young children. Young children under the age of 10, their diagnosis is going to be disruptive mood dysregulation disorder. Children with depression often do not present with the classic symptoms of the depressed mood that we expect to see. Kiddos with depression tend to present with anger, irritability, tantrums. They don't understand their feelings, and so they tend to have outbursts. This diagnosis must occur before the age of 10. If I didn't say that already, that might be important. Depression in youth and adolescence. Suicidal ideations are very prevalent with depression in youth and adolescence, so we always want to be monitoring for that. Girls are more likely than guys, teenage girls are more likely than guys to rely on emotional communication and share their emotions. Why do you think that might be? What's leading to that? That teenage girls are more likely to share how they're feeling than teenage guys. Abby? Bingo. So teenage guys are at high risk because they are not likely to share how they are feeling. So we have a higher rate of depressive symptoms in girls, but there is a thought that some of that might be related to the underreporting in guys. Subtypes of depression. Remember, we are not diagnosing, but you need to know these because you will see these terms on the inpatient units. Atypical depression is depression that has uncommon symptoms. Atypical depression is somebody is depressed, but then something positive happens and they kind of have this burst of happiness and then they go back to being depressed. And then something positive comes up and we feel better for a little bit. And then we go back to being depressed until the next positive event. Melancholic depression. What is anhedonia? I mentioned it a little bit ago. What is anhedonia? Yes, decreased interest in activities you used to like. Catatonic depression is significant alterations in movement, whether that's a lot of movement or almost no movement. Peripartum depression. Did you guys talk about this in maternity? Okay. Pregnancy in the first 30 days after the baby is born. This is very serious. This is something anybody want to work for women's health? All right, you women's health nurses are going to be screening for peripartum depression. My sister had peripartum depression. I called Kristen Slaybaugh and said, I need a crash course on how to, I left work to come to her house because she actually called me up and said, I think I need to bring my baby to the hospital. I don't think I'm a good mom. I don't think I can do this. I spent most of winter break that year at my sister's house. Her son's 2, and she says to me, don't you ever tell him that I wanted to give him away. I absolutely love him. She said she never wants another kid because she doesn't want to go through that depression again. Psychotic depression. Depression with delusions and hallucinations. This is very challenging to diagnose. I'm not going to ask you psychotic depression on an exam because it gets very sticky between, is it depression? Is it something else causing delusions and hallucinations? But you may see that in a chart. It is a thing. It's very rare. Lots of criteria to diagnose it. Seasonal depression. You may also see that called SAD, seasonal affective disorder. So with the changes in seasons, people tend to become depressed. What seasons do you think people are more depressed? Winter. Why? It's dark. You get up and it's dark. When you go to work, you get home from work and it's dark. I hate working day shift in the winter. So where does depression come from? There are lots of theories, neurochemical theories. What neurotransmitters do we know are affected by depression? Serotonin, high or low in depression? What other neurotransmitters? Levi. Okay. Are they high or low? Low. 2 other big ones. Wait, no, you said norepi. 1 other big one. What other neurotransmitter might have something to do with depression? Starts with a D. Dopamine. Genetic. There is a genetic connection with depression. Circadian rhythm theories. This is kind of related to the seasonal depression. So if you have sleep disturbances, people who work rotating shifts, that can put you at an increased risk of depression. And there are some changes in brain anatomy, damages to areas of the brain. What area of the brain might we think might have damage for somebody with depression? What area of the brain? What region? What is the emotional center of your brain? Yes, the amygdala, and in larger case, the limbic region of your brain. Psychological theories. These have to do with your history. Psychoanalytical theories say that you had a significant loss at some point in your life. Cognitive theories have to do with how you think. If you have negative thoughts, you'll have negative behaviors. Interpersonal theories have to do with the fact that we as humans are social creatures. And so if you don't have relationships and supports, that can lead to depression. And psychosocial, psychodynamic views look back at what are your early childhood experiences and how did you learn to respond to stress as a child? Do you have good coping strategies? Do you have ineffective coping strategies? So, considering different populations, 7% of all adults suffer from depression, and about 80% are going to have recurrent episodes. So depression is usually not an isolated event. Older adults, depression is often misdiagnosed as dementia. We tend to call everything with older adults dementia. Oh, that's dementia. Oh, that's a normal part of aging. Depression is not a normal part of aging. Children, in case you didn't pick this up before, tend to have irritability. We need to be considerate of cultural differences in depression. Asian cultures often describe depression somatically. They describe it based on their physical feelings. So they may describe depression as a headache, as abdominal pain. And Indian cultures tend to describe depression as feeling out of balance. Gender. Males tend to exhibit different symptoms than females. Men tend to exhibit more anger with their depression, more irritability with their depression. So, our role as the nurse, we're always accepting the client as they are, focusing on strengths, encouraging their self-worth, validating the emotional pain, and providing appropriate decision-making opportunities. And I think I've discussed this before, but sometimes we give somebody so many choices, they're overwhelmed. So narrowing it down to a few choices, but that they're still making their own decisions. Do not stand there and outline why someone is a worthwhile person. They do not want to hear this. It is not helpful to them. Do not promote dependence on the mental health system. And I know we did a devotional on dependence on God. Dependence on God is different than dependence on the inpatient mental health system. We want to help get people back in the community functioning at the highest level possible. Do not argue about negative beliefs, delusions, or hallucinations. You're going to end up in a circle. Medications. We're going to talk about antidepressants and other psychopharmacological treatment. We have two categories of medications for antidepressants. Those that block the reuptake of neurotransmitters and those that inhibit the breakdown of neurotransmitters. Both of them have a goal of increasing the amount of neurotransmitters in the synapse. So reuptake inhibiting antidepressants are going to block these channels that the neurotransmitter can't be sucked back up in the cell, leaving it more in the synapse. Enzyme inhibiting ones are going to slow the breakdown, so that if the breakdown's slower, there's more in the synapse. So SSRI, selective serotonin reuptake inhibitors. You have a list of them on your drug card. You need to be able to recognize a drug and know which category it goes into. I will give you both the generic and trade names because lucky for you, NCLEX changed. When I took it, you only got the generic names. SSRIs inhibit the reuptake of serotonin. They are selective to serotonin, which means they don't have as many side effects as drugs that inhibit the reuptake of multiple different neurotransmitters. However, I put this in red, you better by the end of this semester be able to tell me what you are looking for with serotonin syndrome. Serotonin syndrome is a medical emergency. I focus on medical emergency items here, safety. So serotonin syndrome, clients are at risk for suicide. When you are administering an SSRI, slow onset, taper the dose to discontinue it. Patients are going to appear sweaty, hot, febrile. They may have muscle rigidity and restlessness and an increased heart rate. You can remember that by SSRI. Things in bold, very important. MAOIs, which we're going to talk about, and tricyclics can cause serotonin syndrome if they're taken at the same time, because all of these drugs are increasing the level of serotonin. We need to be aware in infants, serotonin withdrawal syndrome is a real thing, because remember, we want to taper the dose. Well, if mom's on an SSRI and baby is born, that dose is cut off. So baby's going to start to develop these symptoms. Can't see that very well. Other cyclic antidepressants, SNRIs, serotonin and norepinephrine. They are inhibiting both. So we are worried about serotonin syndrome with these. SNRIs tend to have a high level of sexual dysfunction, which means that they tend to have a higher level of non-adherence from patients. Cyclic antidepressant, serotonin antagonist and reuptake inhibitor, trazodone. You do not often see trazodone prescribed for depression. You see it prescribed for sleep. You will often see it prescribed on the inpatient unit for sleep. Some of these I have on here. We're not going to spend a lot of time on them. I just want you to be familiar that you have seen them, because you might see them on the inpatient unit. I'm not going to focus on them for the exams. So Remeron is another example. Remeron has a faster onset and it does not have as much sexual dysfunction. However, it causes weight gain. So you kind of have this toss up with Remeron versus an SNRI. Another one we're not going to focus on very much is Vibrid. Vibrid, you get the benefits of a serotonin reuptake inhibitor without the effects of sexual dysfunction. You are not seeing a lot of Vibrid because a lot of insurances do not cover Vibrid. So we don't really focus on it, but again, I just want you to have seen it. Serotonin syndrome. If I didn't tell you this was important before, it's important. And this is another slide depending on how you like to visualize things. Cyclic antidepressants, NDRIs, norepinephrine dopamine reuptake inhibitors. What do you think the benefit of these is? What do we not have a risk for? Serotonin syndrome, exactly. So Wellbutrin, they reuptake, the norepinephrine reuptake inactivates dopamine. That's why they work well together. So we like that they don't affect our serotonin levels, but we don't want to give them with drugs that are going to increase dopamine. And very important, the big takeaway for NDRIs, besides not at risk for serotonin syndrome, is they are contraindicated in individuals with seizures because of their impact on dopamine. So we don't want to give them to someone with a seizure disorder. Tricyclic antidepressants. Big takeaway for tricyclics is anticholinergic effects. You may have learned these two different ways. Can't see, can't pee, can't spit, can't poop. Did you guys learn that one by any chance? Other one you might have heard is hot as a hair, dry as a bone, mad as a hatter, blind as a bat, red as a beet. They both are getting at the symptoms of anticholinergic syndrome. I would know the difference between anticholinergic and serotonin syndrome. Serotonin syndrome, SSRIs, anticholinergic, tricyclics. The antidote for tricyclic poisoning is anti-illyrium. I can't say it, but I can recognize it. So I would know the antidote. Tricyclics do not play well with MAOIs. We're going to learn MAOIs on the next slide. Don't play well with anything. So pretty much if MAOI is an option of what it doesn't interact with on the NCLEX, that's the correct answer. They don't go well with anything. So we want to avoid that together. Which brings us to MAOIs. These are very old drugs. You may not see these prescribed. You will not see them prescribed frequently. You often see them prescribed to older adults who have been on them for years and years and years, and they're working, so we're not going to adjust what's working for somebody. But they're often not prescribed they're usually only prescribed as a last resort because there are so many risks. Big thing, tyramine. What type of foods include tyramine? Have you guys learned about tyramine? What foods include tyramine? Eggs, cheese, wine, sausage, salami, pepperoni. Just think, I told Dante, you can never be on an MAOI. I don't know what you'll eat. He's Italian. So think of all the Italian foods. Even things like pickles. We want to be really careful. Chocolate, sour cream. So if someone's on an MAOI, we don't want to put them on another MAOI, an SSRI, a tricyclic, or Demerol. Demerol is not prescribed very much anymore, but we don't want them on any of these things. So how do we remember MAOIs? M, massive hypertension crisis. We need to be monitoring their blood pressure. A, avoid tyramine. O, over-the-counter drugs to avoid. Tums, Tylenol, and NSAIDs. Well, I just wiped out your entire medicine cabinet. Another O, avoid other antidepressants. And I, these have an increased risk of suicidal ideations. So again, usually a last resort. I would know these things here. So non-traditional approaches. Has anyone heard of microdosing with ketamine? You guys heard about that? Okay, that's a big thing right now in Gettysburg. So microdosing with ketamine for depression. What I find though is you have to sign for your ketamine, and then we have patients who come into the ER because their depression is getting worse because they haven't been able to sign for their ketamine, and now it's been sent back to the manufacturer. So ketamine works by increasing glutamate and acetylcholine. Aripiprazole, Abilify, antipsychotic, we'll talk about that later. Anti-inflammatories have been thought to be used for depression to decrease the general inflammation in your body. This is highly controversial. And vitamin D. Most of us in the United States have a vitamin D deficiency. There's a link between vitamin D and depression because vitamin D is needed to convert tyrosine to levodopa and then dopamine and norepinephrine. So not enough vitamin D, low levels of dopamine, low levels of norepinephrine can be related to depression. So how are we going to manage the milieu? Patients that have a negative view of themselves, we want to encourage their participation. And that's also why group norms are so important. That's why we have to set limits as the nurse with other patients that are perpetuating the negative view. Withdrawn patients, brief but frequent interactions. They may not be able to handle a long conversation. Encourage participation. Anorexic patients, encourage them to eat. High fiber, lots of fluids. And patients with sleep disturbances, eliminate daytime napping. If you nap in the day and you have trouble sleeping at night, you're going to have worse trouble sleeping at night. And minimize drinking stimulants. Some of the inpatient units have rules of no coffee after this time, or no caffeinated beverages after this time. That's to help minimize the stimulants. And then most important thing, you take one thing away from this lecture. When is a depressed patient at highest risk of committing suicide? Say again, sorry, I didn't hear you.
Whenever they start their meds.
About 6, yes, about between the first 6 weeks of starting their meds. They now have the energy to follow through. So we want to make sure we continue to monitor somebody with depression for suicide, because as their mood lifts, they may have the thoughts and now they have the energy to carry through. Any questions about depression? We're going to real quickly cover ECT. I only go over ECT, electroconvulsive therapy, because many patients are now seeing this as an option for them. And I want to make sure you're familiar with it so that you can be objective if a patient asks you about ECT. How many of you have heard of electroconvulsive therapy? Okay. It's getting more and more prevalent. So what is it? Electroconvulsive therapy is a treatment for some psychiatric conditions, including severe depression. The patient is actually delivered a seizure under a very controlled environment. You have an anesthesiologist there, you have a psychiatrist there, you have a nurse there. This is actually can be a life-saving modality for patients. And believe it or not, it is safe for pregnant ladies. So there are a lot of meds that are not safe for pregnant ladies. However, ECT can provide them with a safe alternative. So who gets ECT? ECT is for people with treatment-resistant diagnoses. ECT is not the first thing we're going to offer when you come in with symptoms of a psychiatric disorder. We're not going to jump right to ECT. We're not going to give it to you just because you say, hey, my friend had ECT, it works. I want to try ECT. We're going to try other things first because we are literally inducing a seizure. So treatment-resistant depression, treatment-resistant bipolar, usually the depressive part of bipolar, treatment-resistant schizophrenia, schizoaffective disorders. You can also, with patients that have severe suicidal ideations that are at eminent risk, and patients with catatonia, that extreme in muscle movement. Patients with delusional disorders, personality disorders are not candidates for ECT. ECT is not going to change a personality disorder or a fixed false belief. We cannot do ECT on someone who has cardiac disease, or someone with severe pulmonary disease, or someone with a cerebral hemorrhage, stroke, or increased intracranial pressure, because again, we're inducing a seizure. So we want to minimize the risks. I kind of talked about this. ECT, they're going to deliver a, sorry. Any history. Yep, good question. Any history of cardiac disorder, any history of severe pulmonary disorder, any history of a stroke. So if they're scheduled for ECT and they have a stroke, boom, they're done. If they had a stroke 20 years ago, no, not a candidate. Great question. So ECT is often administered 2 to 3 times a week until the patient is in remission, symptoms are getting better, up to 12 treatments. Now, somebody can have 12 treatments of ECT, symptoms recur again. We might do ECT couple months, couple years later. You will have some patients that might be on the inpatient unit and tell you, oh, I get ECT every so many years. When they do ECT, you want to pre-oxygenate the patient. The doctor's going to sedate and paralyze the patient and initiate a seizure. Your job is continuous assessment and monitoring. Before the doctor paralyzes and sedates the patient, you're going to pump up a blood pressure cuff on their lower leg. And then they'll sedate and paralyze them. Why do you think that might be? We're pumping up a blood pressure cuff. What's that going to prevent? Is the medicine going to get to their foot? Nope. We're cutting off the blood flow to the foot. However, we'll be able to see the seizure activity in the foot. So ECT is not barbaric. It is a controlled procedure. The patient is sedated and paralyzed. They are not feeling it. It is not torture. It is also not a cure. So with ECT, we need to provide continuous monitoring. These patients are going to usually have ECT. There's a suite, kind of a surgical suite at the hospital. They go to ECT. They spend about 4 hours in post-op. They come back to the unit. They're usually very tired. They may have a headache when they come back. They may have short-term memory loss. Those are all normal. So we want to continue to monitor them. As nurses, we want to reduce the stigma and educate people on the treatment. Telling somebody we're initiating a seizure is a very scary thought. So you want to explain the controlled environment. Everybody has their own opinion on ECT. I'm not going to ask you to share that publicly, but do not allow your opinion to influence the patient one way or another. Your job is to provide objective facts. Do not promote stigmatization or non-acceptance. Do not continue to promote the, oh, it's barbaric, oh, it's torture. We're going to talk about different meds for ECT. So prophylaxis pre-seizure, we may give somebody Tylenol because we know headaches are a common side effect. We may give ondansetron, Zofran, because nausea can be a common side effect coming out of the anesthesia. The induction agent, you may see methotrexate, and that is the gold standard. I'm not going to ask you this, but methotrexate is the gold standard because it's unlikely to slow the progression of the seizure. You may see propofol or ketamine. I've seen ketamine a lot because it has a short half-life. So the providers like that short half-life. But ketamine has an increased risk of salivation. So because of that, oh my word, I'm blanking. It starts with an A, and it's an ACLS med that we give to help with salivation. Atropine, thank you. Atropine, we may give atropine to help with the salivation. Neuromuscular, succinylcholine tends to be the gold standard. You may see rocuronium. And you may see benzodiazepines given afterward. Not see benzos. We would hold benzos. Why might we hold a benzodiazepine for somebody going for ECT? Do you guys learn about benzos in any of your other classes? Outside of psych, what might we use a benzo with to help? If a patient's having what might we give them a benzo? Seizure. So we want to hold their benzos because we want them to have the seizure. So you may see that. Atropine, another reason we might give atropine. What else does atropine help with? Think back to ACLS. With your low heart rate, right? So patients coming out of ECT may have a low heart rate. So we might give atropine for that. And then ECT is safe for pregnant ladies. Milieu management. They're going to start out in an ECT suite, go to a PACU or same-day surgery. Safety is the #1 priority. So when the patient comes out of ECT, we want to be monitoring vital signs. Heart rate may be low. They may be having increased salivation. We're going to have standing orders for atropine. Nausea. We're going to have standing orders for Zofran. So you want to give those meds as indicated. Continue to monitor the patient. Patients' main concerns tend to be memory loss. Most of the memory loss related to ECT is the time surrounding ECT. A lot of patients are willing to take that risk because their general thoughts are, I don't want to remember this depressive time anyway. So it doesn't affect long-term memory, it affects short-term memory. We want to educate the patient and family and then support the patient when they're back on the unit. They're likely going to be tired and have a headache. So they're probably going to want to rest. We want to make sure they're still eating. Some of these patients that are getting ECT every 2 to 3 days will have an IV in place. So we need to be considerate of the risks for that. Any questions about ECT? Okay, we're going to briefly go over grief, and then we will transition to our bipolar activity. This is going to be real quick. Yep, we're gonna do a break while I get the bipolar activity set up. So grief. Grief is an intense and normal response to loss. Everybody grieves differently. Different types of events can cause grief. The general affect from grief. And what is affect versus mood? Somebody tell me the difference between affect and mood. Bingo. So the affect, the patient appears as though they just are empty. They appear sad or they have no emotions. You may see this come in waves. The idea is as time progresses, these times of sadness, these lows are going to get less low and more wide apart. In general, the severe stages of grief last about 6 months, but there are the pangs of grief that go on and on. Prolonged grief disorder. Grief is a process. However, we are not meant as humans to prolong it. You need to mourn, but then you need to be able to start to feel some joy, love, and get back to living life. It doesn't mean you're not still grieving, but we get concerned when grief starts consuming all aspects of your life. It's affecting your social and occupational functioning. Then you may need more help and support. We call this complicated or prolonged grief. It's impacting your social and occupational functioning. Now, because everybody responds to grief differently, we are saying that the event needs to have occurred at least 1 year ago. So for up to the first year, we would expect some level of social and occupational functioning. But going past that year, we start to think maybe you need some extra supports. 6 months for children and adolescents. And then we're looking at lots of different symptoms. Do they have a disruption in their identity? I have a friend who was in a car accident. She survived. Her daughter, who was 9 at the time, did not. She used to be a nurse, and she has permanent disabilities, lost her ability to work as a bedside nurse. She has complicated grief. Her whole identity was being a nurse and a mom. She, to this day, says she doesn't really know who she is. Some people have disbelief of the loss. Avoiding reminders. She redid everything in her house so that she doesn't have to see anything that reminds her of her daughter. Intense emotional pain, social isolation, emotional numbing, feeling that life has no meaning, intense loneliness. Again, I'm not going to ask you about prevalence. Older adults are at high risk of this because of the compounding number of grief events they're seeing. History of depression or bipolar disorder can make you at higher risk. The primary treatment is cognitive behavioral therapy. We want to change how you're thinking, how you're feeling, how you're behaving. But most people think this is normal and they don't seek out treatment. Grief does not mean you have to live your life without any joy. You're allowed and should start feeling joy and love again. I would know this slide. This will pop up at some point, whether it's on the exam or the final. There's a difference between grief, prolonged grief, and depression. Grief and prolonged grief, we have a known loss. We can connect it to something. Depression tends to be related to many events, many losses. Grief is a shorter duration, generally 6 months to a year. Prolonged grief, at least a year. Depression is recurrent. Grief, you improve and regain normal functioning. Prolonged grief and depression, impaired functioning. Very important. When most individuals are grieving, they respond positively to social contact. My grandfather died in January. My grandmother responds very positively to any social interaction. She wants you to call her. She wants to go out. She wants to have lunch dates. Prolonged grief and depression tend to avoid social contacts. Individuals with grief are rarely suicidal. Prolonged grief may be more common in depression. Grief does not require treatment. Grief is a normal process. Prolonged grief, we're usually going to use therapy. We're not going to use medication for prolonged grief. Depression, we're going to use antidepressants along with therapy. Any questions? Yes, Levi.
Wait, so depression, like it says depression. Depression's within the grief like PowerPoint. So is that like grief depression? Or is that
No,
just
depression is in the PowerPoint because people tend to confuse grief and depression.
Got it.
So I want you to be able to differentiate between the two. Good question. Because some people will classify prolonged grief as depression. They're two distinct things. And the big thing is we're going to treat them differently. Somebody with prolonged grief is not going to benefit from an antidepressant. All right, so it is 10:07 now. So be back at, this 10:15 should give you plenty of time. Be back at 10:15. We're going to watch this video about bipolar disorder, and then we will kind of discuss this case of the patient. I'll give you more information when we get back.